So good evening everyone. So today we'll be talking about the disease called Parkinson. So as you all know about the Parkinson's disease, so you might have come across this disease a lot during studying of neurology or any of the disease related to the medicine. So or you might have encountered during your patients down in the neurology department. So we'll be talking about it in a brief manner. So, starting up with the definition. So, what is Parkinson's disease? So, it is basically the neurological disorder. So, basically, it is the neurological disorder where the basal ganglia is majorly affected. So, what is basal ganglia? It usually consists of three parts. One is globus pallidus, subthalamic nuclei, and substantia nigra. So the contents of substantia nigra usually consists of dopaminergic neurons. Where usually the main function of dopamine, as you all well known about the dopamine is it activates the function of the muscles and controls the brain stimulus. So now talking about the classical symptoms. So what are all the symptoms we usually demonstrate in patients with Parkinson? It usually consists of the dementia, where the patient suffers from progressive loss of memory, recognition, and cognitivity and intellectual ability. And the second one is postural instability. What does the postural instability means? So postural instability refers to the loss of coordination and cognitivity, and there will be huge loss of what you call the uh, the coordination between the body and the movements. And the third one is I have divided the mnemonic into four parts, which is called as trap. The first one is tremor. So usually we see the patients with Parkinson suffering from tremors, where there will be shaking of their palms. So it is called as pill rolling tremors, or rest. We also call it as resting tremors. We also name it as resting tremors. And the second one is rigidity. So what does the rigidity means? Usually there will be a certain kind of muscle stiffness in the body, where the patient will be not able to move his hand or something, limbic parts. And the third one is areflexia or hyporeflexia. So hyporeflexia refers to the absence of reflex. Usually we see the patients where there will be loss of reflex, such as deep tendon reflexes. Deep tendon reflexes usually refers to the knee jerk or any other reflex, such as Achilles reflex or knee jerk reflex. Those all the things. So there will be there will be absence of reflexes in the patients with who are suffering from Parkinson's diseases. And the fourth one is postural instability, where there will be a loss, as I've told you, a loss of coordination and cognitivity of the patient. Usually coordination, it is one of the major criteria for motor loss. So you can also put it over there. So and the first and last is hypomimia. So what is hypomimia? In this kind of symptom, we usually see that the patient will not be able to express the things which has to be conveyed. What we call it as is there will be loss of facial expressions. Loss of facial expressions. Okay. So these were the classical symptoms I wanted to discuss with you. So coming up to the causes of Parkinson's diseases. So it is one of the major thing that the age contributes to the main cause of Parkinson's diseases. So usually we see that people who are around around 60 or more than 60, they are more prone to Parkinson's diseases. And if irrespective or regardless to that, if the dementia is seen less than 60 years of age, so we usually call such kind of dementia senile dementia. It is basic thing that we usually come across with the patients who are above 60 and suffer from dementia. If there is a dementia seen in the patients who are lesser than 60 years of age, then we come to a conclusion that it is a kind of senile dementia. In case of senile dementia, we also see in diseases such as Alzheimer's. So Alzheimer's diseases, as you are well known about that Alzheimer's disease, it is a kind of disease where the acetylcholine levels are low in this level. And in case of Parkinson's diseases, I have told you that there will be lack of dopamine or less amount of dopamine production in the brain. And the second cause is post-encephalitic Parkinsonism. So post-encephalitic Parkinsonism, it refers to the patient who have suffered from encephalitis, whether it may be due to West Nile virus, or either it may be due to what you call it as excuse me, please. Either it may be due to West Nile virus, either it may be Japanese encephalitis, or either it may be tick-borne encephalitis. Okay, and the third one is drug-induced Parkinsonism. So there are three major drugs which can lead to Parkinsonism, such as reserpine, botulinism, or what you call the botulinum toxin, and the third one is olanzapine. As you have studied in pharmacology, that olanzapine, it is a atypical antipsychotic drug which is usually used for emesis or vomiting, or either due to chemotherapy induced emesis, or during pregnancy condition. It is also used for what you call hyperemesis gravidarum. In hyperemesis gravidarum, we usually go for the first drug, what you call it as clozapine or any other antipsychotics. So regarding this hyperemesis gravidarum, there is a fact that we usually go for a diphenhydrinate or diphenhydramine as a first drug of choice for vomiting, or if it is uncontrollable, then we go for olanzapine. In olanzapine condition, if the patient is under olanzapine, or if a person is taking excessive amount of olanzapine, it usually blocks the D2 receptor, which is called as dopamine receptors. So dopamine receptors, as you are known, as it is a basic factor that it helps in production of what you call it as dopamine. So if you block the receptors of the dopamine, then there will be less amount of dopamine production or the secretion, and it may also leads to Parkinsonism. And the fourth one is trauma. Okay. Now coming up to the pharmacological aspect of Parkinson. So there are two major drug of choice which you use for Parkinson which are levodopa and carbidopa. Before going to the pharmacological aspects and other things, I wanted to discuss you with one of the major circle, which is called a circle of hypothesis, or what you call it as theory of hypothesis. So consider a patient who is approaching you, and he or she is suffering from Parkinson's disease, or he or she might be demonstrating the classical symptoms of Parkinson. So we usually go with the drug of choice called as L-dopa. So there is one of the major side effect what we come across is L-dopa. It usually increases the amount of dopamine, but besides it usually decreases the amount of acetylcholine in the brain. So if there is decrease in acetylcholine in the acetylcholine production, then obviously, like, it is a matter of fact that it may also leads to another disease called as schizophrenia. So we usually encounter with the patient who are suffering from Parkinson, and if the patient has undergone the treatment with the help of L-dopa, then there are high chances that we may manifest the patient may manifest the symptoms of schizophrenia. Okay. So this is called a circle of hypothesis. Okay. Now coming up to the another type of Parkinson, it is called as atypical Parkinsonism. So this atypical Parkinsonism, is like it is the same type of disorder which we come across usually in Parkinson, where the manifestation or demonstration of the symptoms are similar to the Parkinson, but there are some criteria which we use for differentiation for Parkinson disease and atypical Parkinsonism. So in Parkinson's disease, there is usually cogwheel type of rigidity. Means there will be the onset of rigidity will be early in Parkinson's disease, and it will be a type of cogwheel. And talking about atypical Parkinsonism, it is a kind of lead pipe rigidity. So in this type, the rigidity, the onset of rigidity will be late in atypical Parkinsonism, and the dementia and postural instability, which are two major criteria which we use for diagnosis of Parkinsonism, is it will be there will be later onset of dementia and postural instability. But as in case of dementia and postural instability, it is seen earlier stages in atypical Parkinsonism, and even the cognitivity is also like the loss of cognitivity also is also seen in early onset of atypical Parkinsonism. But in case of what you call Parkinson's disease, it will be in the mid stage onset of the loss of cognitivity. So there are certain subtypes of atypical Parkinson's which we'll be talking about. The first subtype which we are going to talk about is MSA, which is multisystem atrophy. So in multisystem atrophy, we usually see the autonomic imbalances in the patient, where there will be like deviation of heart rate, or it may present as a loss of micturition, and even in case of lacrimation, where there will be excessive amount of the secretion of the water in the eyes, what you call as watery eyes. Okay. Because there will be as the autonomous nervous system consists of two types. One is sympathetic and parasympathetic. So in this, there will be imbalance between the sympathetic nervous system activity and parasympathetic nervous activity. So if we encounter the multisystem atrophy case in case of Parkinsonism, we usually denote it as MSAP. And if we encounter the patient with suffering from multisystem atrophy with cerebral ataxia, so usually if a patient is suffering from cerebral ataxia, then there is obvious case that the patient may present symptoms such as loss of movements, and there will be imbalance between the coordination and cognitivity, and there will be the loss of the balance while movement, and high cases of bradykinesia. Now coming up to the corticobasal degeneration. So in this case, there will be loss of cognitive functions and motor loss, and we usually come across with the major symptom, what we call it as alien limb phenomenon. So this ALM limb phenomenon plays a huge role in corticobasal degeneration, which is that if we see a patient coming to you, and you're gonna approach with a treatment. So usually there will be asymmetric loss of the movement in one limb. Suppose if I give an example to you, there will be like you know one the right hand will be completely in the form of rest, where there will be no movement seen in the right hand, and there is and in terms of left hand there will be complete movement seen. Like there will be no abnormality present in the left hand, and there is complete abnormality present in the right hand. Okay. So this is called as alien limb phenomenon. Now coming up to the third one, which is PSP, that is progressive supranuclear palsy. So in progressive supranuclear palsy, the patient usually presents with the symptoms such as visual gaze, where the patient will be not able to see upside or move his eyes upwards because of the loss of the movements of extraocular muscles of the eye, and there will be early falling of the patient. The early falling of the patient refers to the, like, there will be loss of movement, and the patient will be not able to you know perform the movements which is a criteria for day-to-day daily activities. And the first and last is DLB, which is called as diffuse Lewy body dementia. It is a kind of tauopathy, where the usually tauopathy means we have studied it earlier in Alzheimer's, where there will be accumulation of abnormal proteins in the brain. So that abnormal protein is called as alpha synuclein. So it usually accompanies as a clump in the brain, and it may lead to the defective functions of the brain. So it is called as Lewy body. Now coming up to the diagnostic criteria. So the diagnostic criteria usually refers to the MRI and CT, where the CT or MRI shows the brain atrophy of the brain atrophy present in the all lobes of the brain, and the amount of synuclein proteins in the brain, where you usually perform lumbar puncture with the help of the instrumental approach. And the third one is physical examination, what we call it as Bishop score. So Bishop score usually it is used for the it is used to evaluate the patient with day-to-day daily activities in aspect of their movements, and the amount of reflexes that demonstrated by the patients. So the last thing is the treatment, the management of Parkinsonian patients, which is the pharmacological aspect of this disease. So we usually go for dopamine agonists such as cabergoline, bromocriptine, and pramipexole, and MAOA and MAOB inhibitors. MAOA refers to the monoamine oxidase inhibitor. So there are two enzymes present in our brain, which inhibits the synthesis of dopamine, which is monoamine oxidase, which are A and B. These two enzymes helps in the formation of dopamine, not formation, the degeneration of the degeneration of dopamine. And the second one is selegiline, where the example presents such as selegiline and rasagiline. And the third one is COMT inhibitors, which are catechol O-methyl transferase inhibitors. So it is one of the major enzyme which is usually present in the basal ganglia, which helps in the synthesis of which helps in the degeneration of dopamine. So if the inhibitors which we use are entacapone and tolcapone. So the entacapone, nowadays we usually go for the tolcapone as the first drug of choice, because the tolcapone, there are high cases which you have come across of hepatotoxicity in the patients. And talking about the surgical approach, it is usually the thalassotomy, where there will be a mild excised incision and removal of thalamus of the brain, and the deep brain stimulation, where we usually connect the electrodes in through the help of craniotomy, and stimulate the basal ganglia of the brain. Okay, so this was a kind of short note type, kind of a short explanation of Parkinsonian diseases. So I think this might be helpful for you guys. So thank you, and see you in the next time. Thank you so much.